Carol Overtoom, and I am the professor for your course, Mental Health for the Primary Care Practitioner. From the beginning, when you talk to someone, they will tell you that they knew the kids had ADHD from the time they were born, some in the womb. If you read Kaplan and Sadek, you will see that it is something they have very early on. The reason that they don't seem to have symptoms until later is because little kids are expected to run around. When they get to preschool, sometimes that doesn't work out well for them. Sometimes they get through preschool. They get to kindergarten and they're expected to be a little more serious, so that doesn't work out too well. Then again, sometimes around second or third grade is when the teachers get serious about what they expect from the kids, and that's when it shows up. Some kids get as far as middle school, and in middle school you're expected to remember which books to bring, which pamphlets to bring, where you have to go, look in your backpack, have a note, what kind of homework you have, and kids fall apart then. And again, some high school. So if you're asking someone for some details, you need to start from the beginning, and you need to talk to them about what they were like from the beginning. If it's an adult, you can ask them how they did in school, how they did if they had a child study team evaluation, and if they failed, if they did a good job, and you know, it's possible that they got to adulthood with ADHD and just didn't need medication or were not diagnosed. That's possible, and that happens a lot. Medications, well, let me start somewhere else. First of all, you need to be sure you're dealing. Before you start medicating patients for ADHD, you need to think about what other diagnosis could it be. It can, you know, being unable to focus can be many things. It can be ADHD. It can be anxiety. It can be depression. It can be PTSD, any kind of trauma, especially with children. So you need to rule those things out. You need to really think about, is this ADHD? Before you start any medication, you do an EKG, and then you decide what medication. If it's an inattentive type, you can start with Strattera. I find that Strattera doesn't work very well for most kids. It works for adults, but not for most kids. And then we can talk more or email each other more about other medications and what medications you would use to start. This course, before your midterm, we are going to go over ADHD, depression, anxiety. Let me look at my list here. Symptoms for kids in depression is the first symptom that kids have is anger. So lots of times you'll see kids come in and they'll say, well, he has ADHD and oppositional defiant disorder, when in fact he may have depression. I think in primary care, you're going to deal mostly with ADHD, depression, anxiety, and PTSD. So that's where we're going to start. You will need to go over these things for your midterm. So symptoms for depression, what are the target symptoms, what medication, how much, how long, when do you stop the medication. Starting medication for depression, I can't tell you how many primary care people start SSRIs. They look in a book, it says Zoloft 50 milligrams, so they start at 50 milligrams. And the person then develops what we call akathisia. And so we'll discuss akathisia a little bit in our interactions. So when you would start a medication, you start at the very lowest dose. So Zoloft, even though the book says 50 milligrams, you would start with 25 milligrams or split a 25 milligram dose in half and start with 12.5 milligrams. So these are things that we're going to go over and we're going to talk about. Anxiety will be covered, including social anxiety, OCD. OCD is very interesting. It too starts at a very young age. If you ask an adult with OCD when did your OCD start, they'll tell you second, third grade they knew that they had OCD. I had a child, a 17-year-old, that told me when he was in second grade, he could only take so many steps into the classroom, and then he had to take so many steps out of the classroom. So people are afraid or embarrassed. They're embarrassed by OCD symptoms, so sometimes they won't tell you. But if you push and you ask certain questions, for instance, if you ask people, do you ever count words? When someone is talking, you can't concentrate on what they're saying because you're busy counting how many words they're saying. That's a good indicator of OCD. So we'll go over that. We'll go over social anxiety, simple phobias. The only thing that can help phobias, school phobias, whatever they may be, is desensitization. It's well researched. And we can start medication and help people get through the pain of what they're going through. But it's not really going to be the cure. So most patients need to go through therapy. And that includes depression, anxiety, and PTSD at the very least. Panic disorder, we need to cover symptoms of panic attacks. And you need to ask your patient when he comes in, if he has panic attacks, what are his symptoms? Because what sometimes happens is he may have 12 symptoms of panic attacks. You medicate him, you try and help him, and he's still having panic attacks, but you find out he's only having 3 or 4 symptoms. Well, that might be as good as it gets. So we're going to go over that. Agoraphobia, that's a tough one. Again, people, I don't know if the right word is are ashamed of it, but they minimize it. You know, they say, well, I don't feel like going out with my friends anymore, and I like to stay in the house. So you have to really investigate what's really going on. So those things will be covered this first part of the semester. PTSD. Start reading PTSD right now. You're going to read it, and reread it. Because what often happens is people come in with a lot of different symptoms, And it turns out that they really do have trauma, whether it's sexual trauma, whether it's trauma from when they were little kids, whether they've been beaten, they don't want to tell you what happened to them, what's going on in their family, domestic violence. Very often it's PTSD, and it's really your job to find it, to get that differential diagnosis. I had a child recently. She's 16. She said she was suicidal. She was going to kill herself. She has all these somatic symptoms. She has backaches. She gets headaches. Everything is wrong with her. At about 12 years old, she went to a rheumatologist, and the rheumatologist told her he was going to put her on some medication and run some tests. Well, Mom didn't have money to go back to the doctors, so she went to the primary care doctor, and this patient has been on medication for the past 3 years because the primary care doc just kept refilling it. And her diagnosis was listed as fibromyalgia at 12 years old. So it's that kind of thing that you have to really watch for. You have to make sure it's not trauma. So we'll do a midterm, and I'm not sure how we'll do the midterm yet. It will be case studies, and it will be a number of case studies to see if you recognize psychiatric diagnosis. One thing I always tell my psychiatry students is to make sure that you rule out medical problems. And so I will tell you that make sure when you're treating someone that you rule out psychiatry problems. Okay, well, we'll go over more of this. The next thing after ADHD, probably depression. I'm looking at my notes here. Probably depression. And then we'll move to anxiety, and then we'll cover PTSD.